An 83-year-old male who is a known diabetes and hypertensive came to our OPD with complaints of unilateral left-sided headache for 3 months duration. On an average, he is getting 30 to 40 attacks per day, and each attack is lasting for few seconds to 4 minutes. The pain is localized to the left periorbital region, and the intensity is moderate to severe with sawtooth pattern and a stabbing quality. The pain is aggravated by cutaneous triggers, chewing food and brushing teeth. And most importantly, this pain is also associated with lacrimation and conjunctival injection. He took consultation from an ophthalmologist and an ENT surgeon for a local cause, and it is found to be normal. He was treated outside with analgesics and amitriptyline. So this is an unilateral headache localized to the periorbital region associated with autonomic features. We made a probable diagnosis of trigeminal autonomic cephalalgias, and the closest DD for this is trigeminal neuralgia. The points against trigeminal neuralgia is the presence of autonomic symptoms and the distribution of pain in the face. In trigeminal neuralgia, the pain is mostly distributed in the maxillary and mandibular division of the trigeminal nerve, and the autonomic symptoms like conjunctival lacrimation, nasal stuffiness and oral fullness are almost nil. So let us come to our case, trigeminal autonomic cephalalgias. In the spectrum, we have three important headaches. One is cluster headache, second one is paroxysmal hemicrania, third is shunt or short-lasting unilateral neuralgiform headache with conjunctival tearing or SUNA. Let us look into this table and compare with our patient's history. So in cluster headache, each episode of headache is lasting for 15 minutes to 3 hours. So the probability of cluster headache is very less. Our patient is already treated outside with analgesics for past 3 months without any response. So the chance of paroxysmal hemicrania is also unlikely, because paroxysmal hemicrania will respond to analgesics like indomethacin. So we made a diagnosis of shunt or short-lasting unilateral neuralgiform headache with conjunctival tearing and started the patient on lamotrigine 100 mg. IV lidocaine is the abortive therapy, but we didn't use it in this patient because the patient's symptoms started to settle with lamotrigine therapy alone. In the meantime, an MRI brain was taken to rule out two important things which are secondary causes for trigeminal autonomic cephalalgias. One is pituitary lesion, second one is posterior fossa tumors. So we made a probable diagnosis of primary short-lasting unilateral neuralgiform headache with conjunctival tearing, simply called shunt.